Welcome to the Clinical Prehospital Care Research Forum Journal Club. Here in our PCRF Journal Club, we promote evidence-based practices by critically evaluating the latest science in emergency medical services. We hope our discussion will help advance EMS practice. Through the generous support of our sponsors, Limmer Education and ESO, we are able to make science more accessible and understandable.
Welcome, everyone, to the August 2024 edition of the Pre-Hospital Care Research Forum Journal Club podcast. Special thank you again to our sponsors, Limmer Education and ESO, for making it possible for us to be here together today. I'm Dr. Remley Crow. Today, I am joined by Dr. Tony Fernandez, Dave Page, and we're really fortunate to have with us today one of the authors of the paper, the lead author, in fact, Dr. McCann Pinio. And the name of the paper that we will be reviewing, as a reminder, is the Female Emergency Medical Services Experience, a Mixed Method Study. This is hot off the press, open access in pre-hospital emergency care. We talked about how important that is. Everybody can read this paper for free. I'll be dropping the link in the chat here in a moment. But first, couple of announcements. As always, this article will be this discussion will be paired with an article written by our very own columnist, Michael Caduce in EMS World. The column is called Journal Watch. I encourage all of you to check it out. It's at emsworld.com under the category of education and training. And for those of you who are here live with us today, thank you. As I begin, I want to remind you, you can use the chat feature on your screen the entire time as we go along, type in questions and comments, and we will bring those into the discussion as we go. All right, so with that, welcome, Dr. McCann. We're excited to have you with us today. Thank you for sharing your time.
Thank you for inviting me. It's a pleasure to be here.
Well, as we get started, I think it would be great for you to tell the audience a little bit about who you are and how you got into this world of EMS research.
Sure. So you can all refer to me as Molly. I'm currently the director of clinical research for the emergency medicine service line at Northwell Health, which, if you don't know who Northwell is, it's the largest healthcare system in New York. So I'm based right around New York City. I started pre-hospital and emergency medicine related research during my doctoral program. And so it's now been almost a decade since I started, which I'm significantly aging myself by letting you all know that. But yeah, so I did my research assistantship in EMS and EM and absolutely fell in love with it. Completed my degree in epidemiology and then came to Northwell Health for my postdoc and then got my position that I have now in emergency medicine. And I'm happy to report I have one more day of EMT school. So I'm pretty pumped about that. I take my skills exam tomorrow and hopefully it's a national certification exam and I'm going to be welcomed to the crowd.
We have no doubt. That's really exciting. Congratulations.
Thank you. Very excited.
Yes, we'll be rooting for you.
Thank
Minimum
you.
length test.
Yeah. Fingers crossed.
Yes. Awesome. Well, I don't want to take away that this paper has so much to unpack in it, and I'm really excited to be discussing it. So for those of you who haven't dove into the paper yet, I just put the link in the chat. It is open access, so everybody can read it for free. And to remind everyone of what the objective of this paper was, the goal was to understand and characterize the occupational experiences of women EMS clinicians. And before we actually go into any of the methodology, I always like to talk about the importance. And so what was it that drove you to take on this topic?
Honestly, it was just my anecdotal experiences working with, pre-hospital providers and just the nature of my research. So my dissertation focused more on opioid overdose in the pre-hospital setting. But since coming to Northwell, I do have a dual faculty appointment in occupational medicine, epidemiology, and prevention. So I kind of shifted more into like the occupational well-being of EMS providers. One, because it seemed like nobody cared, and that bothered me. And even more so, nobody really seemed to care about female EMS providers. And I have many paramedic friends who are mothers, and to me, it just seemed kind of impossible how they did it. So I wanted to be able to understand that a little bit more.
I love that. And I love that quote. Nobody cared. And it bothered me. I think we share a lot in common. And my dissertation was specifically focused on burnout in EMS and this workforce health. And this is touched on here so well. I can't wait to dive into it more. But it is great to see the level of attention and focus on this. And I want to bring on Tony Fernandez so that we can talk about some of the methodology here, because good methods make for a good paper. And this study actually has great methods. So I am excited to talk about, what is mixed methods? This is maybe a new term for a lot of us, and especially this qualitative work that was done, because it is no easy feat to read these transcripts and make sense and turn them into data. So really excited to turn it over to Tony for that.
Yeah, and I just want to thank you again for joining us today. I think this is going to be a really exciting conversation, and what is a really good research study. So mixed methods, again, as Dr. Crow just mentioned, this may be unfamiliar to some of the folks on our call today. So just a brief kind of summary of that. This is where you were able to mix some qualitative focus groups with some self-report in a survey. And can you kind of just walk us through kind of 30,000 foot view of how the mixed methods of your study shook out?
Sure. So this study was grant funded. And I originally had applied for a grant because, after a literature review, there's nothing on female EMS providers specifically. And again, that bothered me. So I was like, all right, well, since nothing's out there, traditionally in research, you do a formative evaluation, meaning you just go out there in one way, shape, or form and try and collect some, rich data to be able to drive any type of quantitative study. So that's where the focus groups came in. And we thought about doing individual interviews, but given the peer nature of EMS and the importance of peers, that's why we wanted to do focus groups. So we recruited across the Northeastern region to do a couple of focus groups. Scheduling was a nightmare. Trying to get EMS clinicians into the same, Microsoft Teams room was very, very difficult. So recruitment was very challenging, despite trying to make it as convenient as possible I was on calls at 9 o'clock at night and, having it be virtual. So trying to accommodate our population was difficult. And that's ubiquitous across EMS. That's not just female EMS providers. That's all EMS. So all of my research that I do qualitatively with EMS providers face the same issues. We did incentivize, which I think helped a little bit. But we knew that we needed to have at least 2 focus groups to reach what is called saturation, meaning that there's, no new ideas or themes coming out of it. And we held 2 and then recognized that we didn't reach saturation yet. So we had a third focus group session, and that actually was our most attended, and that's where I felt we got the most rich qualitative data. I don't know if it was just they were just more chatty or they had a lot more to say, but I felt like that third one kind of really solidified all of the themes and what we encountered.
Fantastic. And so it's not easy to find folks to participate, particularly in focus groups like this. That's challenging, especially for new researchers. And I think you had an interesting way of cracking this nut, so to speak. So how did you go about recruiting for your study?
So I'm really, really lucky to work with one of the largest hospital-based EMS systems in the nation. So I have a direct line of access. So I did kind of cheat a little bit.
That definitely helps. Yeah.
But even with that cheating, getting people interested, like Remley has spoken about, the burnout is real. The mental health burden is real. Nobody wants to stay at work or do work longer than they have to, especially post-COVID. So I tried to be a little bit more mindful of that. Incentivizing definitely helped. So, obviously blasted to our EMS agency. I am fortunate enough to have a lot of connections within the EMS world across the Northeast, based, from collaborations from my postdoc or from my doctoral program, and as well as other individuals who are involved in the research that have their hands in other types of listservs, or I know this EMS agency, do you want me to reach out to them? So it definitely was convenience. It was just, hey, can anybody just post this at your volunteer agency, at your paid agency? Please just help us. You'll get paid for it. So that's kind of what we did. We knew that recruitment, like I said, was going to be difficult. It's inherently difficult in EMS. But this is such a really sensitive topic, and a lot of people don't want to talk about it and won't talk about it. So I was a little bit nervous that we wouldn't find people, but I think, once it started, we were able to find enough people for focus groups.
Yeah. And you didn't just recruit, you also had a screening process, right? Because you wanted to make sure you brought in the appropriate population. So
yes,
that also can be difficult. And how'd you handle that aspect of recruitment?
So we actually had a lot more people who we used an electronic red cap survey, which is just like a secure database, and we screened providers. So obviously we had to screen out males, or those who identify as males, just because we wanted to just obviously understand the female experience. We also had to ensure that they were a licensed or certified clinician, active, meaning you were on an ambulance currently. So this weeded out a lot of, now administrative or operational, more, out off of the scenes, not to discredit or, devalue their experience, because they were once on the road too. It's just, we wanted to be able to capture the current state of the EMS experience, particularly post-COVID. So that's why we also had to screen out those people. There are some people who were nurses, that got in there. So you never know who is actually going to click on your link. So that's why it's really important that you have a screening process, so you're able to truly capture your target population and make sure that they are as representative as humanly possible to who you really want to enroll in. That, for us, that's all female EMS clinicians in the US.
Yep. And it's incredibly important to make sure that you have the right population to answer your research questions. So I think that was a really important step in your research. And so the goal was to conduct focus groups, and you were able to have 3 focus groups, and they were each approximately about 90 minutes. And you did that online.
Yep.
That's correct?
Virtual.
Yep. And you had some variations in the number of participants. And that, I want to kind of tease that out for our audience, because that can be a really big deal. The way you deal with, so you had 5 individuals in the first one, 4 in the second, and then 13 in the third one. And there's a really big difference in how you handle those focus groups. So can you talk to some of our audience about how you maneuvered those waters?
Right. So our first 2 focus group sessions, we had confirmed at least anywhere from 8 to 12. And that's typically where I like to keep focus groups. That's like that sweet spot. But obviously the day of, people don't show up, right? That's just how research works, unfortunately. And like I mentioned, some people like to talk more than others. So, the smaller the group is, the more probing that you have to do, meaning, like, could you tell me more about that? Or could you elaborate on that experience? Or, we would have to interject little types of probes, like, did any of you experience a pregnancy, as an EMS provider? So the first 2 groups, there was definitely a lot more work on my end, being, the interviewer. And we have obviously a semi-structured interview guide that we stick with certain amount of probes to not lead the participants, but to try and, obviously elucidate their experiences. And obviously smaller focus groups are a little bit more easy to manage. The last focus group, which was 13, it was only supposed to be confirmed 10, and then somebody, I think, had a bone to pick, so she told someone and someone told someone, so we had 13. So that was a very big group. They wanted to talk for 5 hours and I had to, I'm like, we're at 90 minutes, guys. I'm really sorry. You can email me later if you want. So trying to manage, people talking over each other, especially because it was virtual. There, people in the chat are pinging off and I'm trying to have my poor, research assistant, keep track and write notes and everything. And that also makes it difficult if you have AI transcription, which is what we did. So picking up on multiple people speaking at the same time, you literally get gibberish. So you have to go back and listen to the audio and make sure that you have everything, confirmed. So, there's plus and minuses, but like I said, I typically like to keep that sweet spot. 10 is my number, but anywhere from 8 to 12 is typically where you want to sit. But you take what you can get, unfortunately.
Yeah, absolutely. And I want to emphasize to folks as much preparation that went in to moderating and tracking and recording what comes out of those focus groups. That's not the end of, by a long shot, of what you had to do for this qualitative section. So next there was a coding piece and then an evaluation piece. So I commend you for all the work that went into this. So can you talk to us a little bit about how you took all of this information that you were able to gather with folks in these 90-minute sessions and kind of whittled it down into actionable and usable data?
Sure. So I learned qualitative data, as Remley knows, in, getting your PhD in epidemiology. It's like a 1-minute class. So actually it's like something that just kind of lives in the clouds a little bit.
Yeah.
And unless you do it, you don't truly understand what it takes. So I was really fortunate in my my postdoc that my mentor kind of literally threw me into qualitative data analysis. So and I'm also a creature of habit. So if you find something that works for you, you stick with it. So I use Braun and Clark's, which has seen multiple iterations over the last decade or so now, or 2 decades, maybe, I think, because it came out in 2006. So almost 2 decades ago. And it's a 6-phase approach, and it's an iterative process where you essentially, based off of the transcripts. And like I said, we did use an AI transcription. But like I said, it's not perfect. So there was a lot of going back and retranslating, on myself and the other individual who helped me code and qualitatively analyze. So you essentially, look through every single sentence that every single person said, and you pick up on, little codes or little phrases. So for us, pregnancy happened so many times. So I would just highlight that. Okay, pregnancy is a code. Harassment was a code. Sexism was a code. And it's basically, you look through every single transcript, you code all of them, and then you take all of those and try and group them into overarching themes. And some researchers will use an analytical software to do that, called NVivo, I think is the most well-known one. I don't really like to do that. One, because I never really understood how to do it. 2, it's wildly expensive to get a license. So I kind of just have learned to do this on my own. So you do this independently, and I have, a method to my madness that any of my trainees that I train on this or who help me with it, I ask them to follow the same so that there is a standardized methodology for doing this, right? You can't go rogue when you do qualitative research. There has to be some method to it. So we all follow the same 6 phases, and we all utilize the same type of template to gather our data in the same way in which we abstract these little codes or themes. There's a lot of back and forth between the people who code. So, first we come up with what we think separately, you come together and meet. And then if there's any discrepancies, you have to go back and forth. And there were some discrepancies. So we would separately have to go back to the data and review it and oh, okay, well, I guess that code really could fit into this bucket instead of that bucket. So it is an extremely labor-intensive process. It's iterative. It constantly will change and change and change. And recently, Braun and Clark in their methodology, introduced this idea of reflexology, where it's reflecting back on yourself and your own personal biases. And that was something I didn't really consider until late in the game. And being a female in academic emergency medicine, I knew that I brought a lot of biases to the table, and I did not, and I could not, if I wanted this to be a good paper, influence my qualitative findings in any way. And the person who helped me code was also a female, also in emergency medicine. So we both had to separately do this practice of reflexology, you know, to re-go, like we literally finished data analysis and had to go back and review everything to make sure it was not biased in any way based off of our personal experiences. And we did find that, yes, there was some, you know, like the way that I viewed the whole pregnancy thing, you know, being a new mom, like, okay, like, all right, I got to go back and I need to like put that hat away and look at this, you know, as objective as possible. So qualitative data is a labor of love. It took us months and months to do this.
Wow, I believe it. And again, I commend you on all this work. And you weren't done there. So you took those data and that information, and you developed a survey to collect some quantitative data. So can you walk us through some of that and how you incorporated some of the themes that you found? And one of the things that I really am interested in is you also incorporated some validated measures, which I think is really important. So kind of how'd that survey get crafted and sent out?
Sure. So we used the themes that we found from the focus groups to structure or we contextualize a survey, right? So we have subjective data, and now we need objective data to support that. So we knew that we needed some type of, you know, quantitative data in order to say, hey, what we found in the focus groups is a real thing. Like, we didn't just make it up. So we developed the survey basically just going off of the themes and our structured interview guide and some of the, you know, things that the women in the focus groups brought up to us, you know, even just like anecdotally little things that they would say. I'm like, oh, that's a good question to ask, like about breastfeeding and lactation. Like, oh, I would have never thought about that. Let me ask that. And also, you always want to have some good some good validated metrics in your survey. Because one, reviewers look for it, right? But if it's been done before in your population, it kind of gives you the street cred, right? So post-COVID, you know, we throw a lot of these measures at EMS providers. And given that occupational well-being is a huge research interest of mine, I knew I had to throw some of those metrics in there. And I also wanted to be able to quantify what their mental burdens were at the time, right? Because we know that among EMS providers, burnout and other mental health issues such as, you know, anxiety, depression, just to name a few, are very high at this point, but nobody has like specifically looked at it in just a female population. Yes, it's been split by gender, has been done very, very well post-COVID. But, you know, we wanted to be able to capture among this specific population that we were interested in to be able to explain their mental health burden and say, hey, the people that are experiencing these difficulties, they have a really high mental health or behavioral health burden. So we got to do something about it. We not only have to address their occupational needs, but we have to address their personal well-being needs as well.
That makes a lot of sense. And again, I commend you for all the hard work you did and we've not even talked about any of the results yet. So we've not gone through all of your analysis. So I often have the unenviable task of holding us up from the results to talk about some important methods. I think we've covered your methods pretty well, and I'm excited to talk about your results. But I just wanted to open it up. Is there anything else that you'd like our audience to know about kind of how you develop your study, and I did want to open it up to the rest of our panelists to see if they have any method related questions before we dive into what are some really interesting results.
Sure. I would just have to say, I was met with a lot of resistance with this project, a lot of resistance. I was told, no, you can't do that. No, we shouldn't do that. No, we need to like damper this a little bit. But that didn't stop me. If anybody knows me personally, I'm a very persistent individual. And like I said, this really bothered me. There was so much that just made me angry. And, I wasn't even a clinician. Like, I'm a researcher and I get this, some say ivory tower view of a lot of this, but it just bothered me. And I was told no so many times, but I'm like, nah, I'm going to do it anyway. And well, I guess I just have to ask for, forgiveness later. So I guess I would just, whatever you're interested in research, and people are going to knock it. People are going to tell you it's silly. You shouldn't do it. It's going to ruin your career. But if it means something to you, which for me it did, you just got to keep with it. Just do it.
That's awesome. And I believe personally, this is going to mean a lot to the field. So thank you for conducting this research, and let's jump to some results.
Sure. I think somebody has a question in the chat.
We've got one in the chat and one in the Q&A. So I wanted to make sure we bring those in before we hop off here into the results. One from Dr. Davis was around the use of those validated instruments. You talked about the benefits of using those instruments, but if we're new to research, how do you go about finding a validated instrument like those that you found?
So I think the best way to do that is look at what are used in the literature. Whenever you decide to do a study, you have to conduct a literature review, whether it's exhaustive or not. So that's where I get a lot of the metrics we used. I looked at other occupational medicine published papers. I looked in psychology, and because EMS is the field that I'm interested in, what metrics are typically feasible and acceptable among that population. And then you pick the ones that have been studied the best, and most frequently utilized. So there's no like perfect way to figure out how to do it. I would just consult the literature.
Absolutely. That's really great advice. And now that this contribution to the literature exists, it's nice for us to know that it's been used in an EMS population, and makes it even better when we apply it to a future study. So really great use of the validated instruments. And then I see we've got a question from Joel in the audience talking about, you got a lot of rich data, particularly in that huge focus group at the end there. If you were to explore more on this subject, would you want to do another qualitative study?
Oh yeah, we're hoping to do another qualitative study. I've kind of been called the qualitative girl, so that's kind of where I
like it.
Yeah, that's kind of where I sit, which I don't mind at all, because I love speaking with EMS providers and clinicians and other first responders. So absolutely, definitely would do it again. I think I have 2 studies planned, so definitely.
The best research often brings up more questions than it answered, so I love that approach.
Yes.
Well, let's dive into what this amazing work found, because I think there is a lot to unpack here, but I want to start with some of the results in the qualitative. And I'm starting to share table 1 for those of you who are here live, but this is a really big table, and not expecting us to read it. But at a high level, I'd like to talk through some of the themes that were identified, and then perhaps we can focus in on a couple of the themes and even go into some of the sub-themes, because this is a nice structured approach to presenting the qualitative findings. So Molly, let's talk a little bit about the themes that you discovered. What were they? Were they surprising to you in any way?
So a lot of it was not surprising, but some were. I was very taken back by some of the experiences, or maybe the severity of some of the situations that were experienced. So we had 4 overarching themes, which was 1, the female EMS experience, the impact on personal well-being, the impact on occupational well-being, and coping mechanisms. And obviously you can see there's multiple sub-themes within each of those buckets. And I knew walking into it that I knew sexism and harassment are just very pronounced in first responding populations. It's not just EMS, it's fire, it's law enforcement, it's disaster workers, it's any type of occupation that's inherently male dominated. You will see, these types of issues. So I was not surprised by that. What I was surprised by was some of the severity of the situations described, and just how it's an everyday thing for them. And they're just kind of like, yeah, it just happens. And I'm like, okay, getting like groped by a patient, like to me, that doesn't seem normal, but to them, they're like, yeah, it happens like almost every day. And I'm like, oh, okay. So just like some of like the nonchalantness about some of like these issues. And I guess that is probably just exposure. And, this is just the environment, unfortunately, for some providers. Again, just full disclosure, this is not, to say that this is representative of all agencies across, the nation. This is just what we found in our study, which may or may not be 100% generalizable. Just have to say that just so nobody gets angry at me. But one of the things that I think I was most taken back by was the pregnancy and maternity related concerns. I was actually newly pregnant at the time, and full disclosure, I struggled really, really hard for my daughter. And, a lot of the women discussed how they had to delay family planning, or they've had miscarriages while working. And just how, they can't find a light duty position, even with a written doctor's note. And to me, like, I just found that so mind boggling. Like, I work at one of the largest agencies. Like, why is this not like a guarantee for every female across? And again, this is not inherent to just my EMS agency. This happens at all agencies, struggle to be able to provide that what I think reasonable accommodation would be. So I think that really, again, that bothered me in a really, really big way, that I just was not expecting. And again, I think that was my own naivete. I wasn't, I'm not a clinician. I didn't, truly understand the female EMS experience until they enlightened me with that. So that was definitely, that took me back. And just, the other types of things that we found, like the interactions with male partners. Above all, they said, broadly, their male partners and peers, they have good interactions with, they work well with them, which was good to hear, just because there's so much trust that goes on with a partner, that, if you're in an uncomfortable situation, I can't imagine how difficult that would be to provide patient care. And, the personal impact, the demands on your family, people saying that they are divorced and filing for bankruptcy, like just the financial concerns and the impact on the physicality of the job. And again, a lot of these are ubiquitous across EMS in general, and they're not necessarily gendered, but there definitely are gendered components, especially for moms, right? So, when you have a terrible schedule and you are the default parent and you can't, you work the night shift, like, scheduling childcare and familial care, that's difficult for moms, because the vast majority are default parents, right? So those were some of the things that did have like that little gendered component to them. But again, was not really surprising.
I agree. I think this is an extraordinarily important piece, though, because of what you said early on, and it's treated like normal. Everybody's had this happen to them or had this experience, but putting this kind of data in a research publication gives a lot of support and this notion of it's not just you, as well as can be a real impetus for policy change. So when EMS organizations are struggling to hire, they may want to consider their maternal policies. Do we guarantee light duty? Do we guarantee even maternity? How often are the uniforms not designed for women's bodies and nonetheless maternity pants, right? What are we wearing for tactical maternity pants? But I think this gives organizations really important data as well to think about, well, if we say that we are focused on recruiting a population that looks like the population served, and we know from lots of research that women are underrepresented, particularly in the paramedic workforce, as we go on to career paramedics, this is some information that we can use, and it has great implications for what organizations may choose to focus on and change. Right. I do want to also focus in on the the sub-themes around the coping mechanisms. Perhaps you can talk a little bit about what these women discuss when it comes to coping mechanisms. And one of them might be this idea of, oh, it happens area, I ignore it. But I really wanted to bring out some of this because I think it has so much to do with workforce wellness.
Right. So obviously there were maladaptive coping mechanisms, which we know happen in EMS. I saw it for myself firsthand, doing my clinical rotations. I'm like, wow, you can't go to the bathroom. You have no time to eat. And I'm out in the middle of Manhattan until 3 o'clock in the morning and I'm tired. So like, I totally understand, you grab whatever you can grab to eat. You sleep weird, terrible hours. So there obviously are, maladaptive coping mechanisms, lack of exercise, poor sleep, poor nutritional habits, those things. And as we're seeing more and more post-COVID, there are, increase in the utilizations of substances to help cope, such as alcohol. Nobody in our sample, indicated that they took any type of substance to help alleviate the stress on the job. But, somebody said that they smoke, after a really rough call. Somebody said they get Taco Bell after, their partner always buys them like 2 tacos after a really hard call.
Tacos fix everything, I will say.
Right. So, and honestly, I didn't think that a lot of the deemed maladaptive were that maladaptive, I guess we could say. There was a lot of ignoring. There was like the attitude of, it's fine. It's fine. I'm just going to push it out. Nope, I got to do this because I have 5 more calls. I can't, like it's done. We're going to talk about it later, unpack it later. So those were some of the maladaptive, like the more negative ones that we saw, which I think are very consistent with what's been said in the literature. And I was actually pleasantly surprised for the, adaptive coping mechanism. A lot of female clinicians indicated that they're in therapy, which I was really happy about that, because that is such a, just there's so many occupational considerations to engaging EMS providers in mental and behavioral health care. There's limited resources for a lot of agencies, unfortunately. Being a volunteer versus career status can impact your ability to engage in these types of programs. There's very limited training among physicians to take care of EMS clinicians who have these types of issues because, there's no specific fellowships, and a lot of the women said, my doctor has no idea what I do every day. Literally no idea. So how are you able to treat somebody that, they don't understand the gravity and the nature of your occupation? How are they going to treat you effectively? So there's a lot of occupational considerations that go into being able to engage within and also stick with it, right? So I was so happy that, that was a mechanism for a lot of women. Exercise was for some, which I think that's definitely talked about in EMS, increasing exercise. A lot of people, went to the gym, somebody did a Peloton class every day, they go running. So I think that is also a very positive coping mechanism that I know there is has been a more recent push in EMS, but it's hard to do. I mean, like I said, I was on an ambulance for 13 hours and I was like, wow, I went to the bathroom once. Like, how are you guys going to be able to have the energy to like go run 3 miles? Like I literally came home and wanted to sleep for 4 days. So I totally like understand it now. Like I get it. So I think like keeping that in mind for any type of intervention or how to engage somebody in care is definitely really, really important. But the last thing is that peer support. The other female providers said that their female partners or their female peers are everything. They are the reason that they stay. They are the reason they get through the difficult calls because you have representation, right? You have somebody that looks like you doing the same thing beside you. So there was significant camaraderie, and the value of peer support, and also of their male counterparts. Having that peer support is what carries a lot of these clinicians through and helps retain them, to be quite honest.
I totally agree. And you've hit on so many important pieces here. I'm definitely of the coping mechanism that's going to eat 3 tacos and not run 3 miles. But, I think these are important. But I'm really glad you hit on the part about therapy. I think we are starting to break down the mental health stigma and understand the benefit of tending to our mental health and seeking professional help. And the point you made about when we're seeking professional help, finding those who have experience with first responders and EMS clinicians and understand our world a bit, because what's a normal day for us might seem like the traumatizing part of somebody else's day. And we're like, that's not the part that's bothering me here. Listen to me.
Right.
So I think these are really great things. And that if you're reading this big paper, it's easy to gloss over that. So I did want to take a second and highlight it. Yes. We also have a question from the audience that I'd like to bring in. This is from Dr. Kennel. He's curious about, were there any themes that arose when related to female providers seeking help regarding harassment from their management and perhaps not encountering support there?
Yes. So that was mentioned a couple of times. We didn't think that was enough to generate its own sub-theme. So, we collapsed that almost in like the mistrust, the disappointment. There were many times or a few times that a few of the women who said that they did experience sexual harassment, they tried to go to HR failed them, or they didn't even bother reporting it because they knew that this would happen, or the person that was the perpetrator was their supervisor. So there were quite a few women who did mention that, it happens, but they don't do anything about it because they feel that nothing will get resolved. So they don't even bother. Or it's somebody that they work with every day and have to see, on the same shift every day, and they're afraid of what could happen.
Right. I think that's incredibly challenging, but great that was captured in these interviews. I want to talk a little bit about the quantitative findings, because this was so well done in setting up for, all right, there's nothing out there. We need to take a lay of the land and scope this out. Qualitative research is the best way to do that. But now that we have some ideas, let's see how far this experience goes. Did we truly capture the experience? So this survey was sent out to similar population. There were 224 participants, of whom 148 made it all the way through the survey. And as a survey researcher myself, I can tell you it's challenging to capture the attention for that long, especially in EMS, where our next call might come in at any moment. We had the best intention of returning and it never happened, right?
Right.
So I think getting 148 fully completed surveys is an incredible feat in and of itself. And then I will direct the listeners to table 2, is where we've got some of the characteristics of those who responded. And this is a really important table for us to look at when we think about, who do these findings represent? Are they likely to generalize to other areas? So perhaps, Molly, you could walk us through a little bit of what we found in regards to those who participated, some of their characteristics, and then some of those validated instruments that we talked about earlier. And was there anything surprising or not surprising, perhaps, to you there?
So the population was overwhelmingly on the younger end. As you could see, the median age was 32. So, we had, if they were career medics, career EMTs, they were very early on in their careers. We did have a few who were like the OGs, which you could see 42, they've been in EMS since they were 18. But our population was on the younger side, and they had less clinical experience than I had anticipated. I think it was like 7 years was like the median clinical years of clinical experience. And this was a limitation in our study. As you can tell, the vast majority were non-Hispanic whites. So, racially, again, in EMS, it's already, minorities are already underrepresented. But again, you can see that it is consistent in our study. We did find a very homogeneous population. They were primarily non-Hispanic white. There were a bunch of mothers in the population, and we, like I said, it was primarily Northeast. The vast majority were EMTs versus medics. And some of the validated measures that we used, for occupational stress, we used the SUS-14, and that indicated that it was like a pretty moderate level of occupational stress. It's a pretty wide scale, like the highest is like 70. So, and there is no actual like clinical cutoff for this scale, which again kind of bothers me. But that almost 33 is considered, I guess, moderate stress. But the probable anxiety and depression, I knew it was going to be high, but I didn't think it was going to be that high. Having 70% of your population meet the clinical threshold for probable anxiety, I was like, ooh, that's not good. And almost 54% probable depression, elevated symptoms of burnout. Again, like these are very high, which is consistent with the literature. I guess I just didn't think it was going to be that high. And then, resilience was, as you can see, 17, and the highest is, 20. So I think that indicates that our population is under significant stress, and has high mental health burden, but is resilient too. So I think that speaks to the type of, the caliber of EMS clinicians and what they're able to endure and still show up to work the next day. So I think that also, just like basically looking at our demographics, this can help formulate, what type of interventions you could do, right? And what areas to focus on.
Yeah, and something else to highlight here is, assuming the study was voluntary and you didn't strap people to the chair and force them to take it, that this level of burnout in the population that had the energy to take the survey and answer it suggests this is probably actually underreported. And so the burden is probably even greater. I do want to bring in a couple more questions from the audience since we have them. Diana has a great question regarding, and perhaps this is back to the coping mechanisms, but are you familiar with intensive EMS recovery programs related to drugs and alcohol, and in any experiences of women in those programs, or is that an area for future study perhaps?
That obviously bringing back my, substance use is where I started in, pre-hospital emergency medicine. So being able to merge them together, I'm now starting to get back into that. So I wanted to be able to look at some of the substance use related issues among EMS specifically in our health system, but that's highly protected information. So it is very difficult to not only find, or tap into a data source for that kind of information. But if you were to do like a focus group or something, people aren't going to want to talk about that, right? I think like talking about being a female is very different than talking about like, hey, I have a substance use issue. So again, it's another really, really sensitive topic. And again, is further stigmatized just broadly, but then even more so among first responders. So it's going to be a very difficult thing to study. But again, nothing, what is the saying? Like nothing worth easy, or what comes easy is, I don't know what that saying is, but, it's going to take some time for me to kind of tap in, and you have to build trust. That's the number one thing, is being able to understand for the substance use related programs. And I'm only, unfortunately, like well-versed in the ones that we offer at our healthcare program or in our health system and what's been done in the literature.
Yeah, absolutely. And I think picking the right methods for the right question is important, and highlighting that, not all questions are amenable to focus group, but there may be other ways to explore those questions. In a similar topic from Dre, we have a question around, did you pick up any themes or any comments around hesitancy when it comes to seeking mental health help? Because in some states, and I'm not familiar with New York's rules, there's a disclosure of a diagnosis, or if you've had to seek treatment or therapy for mental health issues, when clinicians go to get their licensure.
That I don't believe is part of New York State requirements. I'm in that process now, and I have not been asked that yet. I think that's not a really great thing to ask, personally. So yes, there was hesitancy in any EMS population that I've spoken, within a focus group setting about accessing to care, there's always hesitancy. There were some women on the call that are like, are you going to tell my boss about this? And I'm like, no, I'm not going to tell anyone about this. So there was some hesitancy, one doing, involving or enrolling within any health system specific program, because there was that fear that this was going to get back to not only the agency, but it was going to get back to somebody, on their shift. And, they say, no, I do everything private because I can't, it's everybody talks about everyone. I can't let anyone know that I talk to anyone. So there is still a lot of hesitancy. And that goes back to the stigma. There is significant mental health stigma. It's a huge barrier to getting into treatment. And I also think just EMS culture in general prevents a lot of people from, or that it generates that hesitancy to engage in, mental or behavioral health. So yes, we did see that hesitancy for sure.
And I think, like you said, we've made big strides, but there's still a lot of way to go. And having this kind of data will definitely help with that. Another question, and I love this one from Joel, is you talked about the implications of some of this work and it being clear in these tables. Have you heard from any agencies reaching out to you about possible ways that they might better address the female EMS experience?
So I have been contacted by a lot of people, but I have the same response they have. I don't know. I don't know what is best. And, I think that's like the crossroad where we're at right now, especially with my research team, is we have found all of this. And now it's like, okay, now what? What's next? And I am so fortunate to work with some of like the best and brightest minds in EMS. And even then, we don't have an answer. Like we don't have the best answer to these questions. So that's where we need to get everybody into a room and start to talk about this in order to make actionable change, right? Because I absolutely do not have the answers. And these other individuals that reach out to me, they clearly don't have the answers. So I'm like, let's talk about it. Let's get a group of people together and let's have a chat, because I don't have an answer for you. And unfortunately, I wish I could solve all of these problems, but I unfortunately can't. So I'm going to need all the help that I can get.
Absolutely. And I think this is the space that gets exciting. This is where research meets quality improvement, right? We have the research. Now, how does the rubber hit the road? Well, we do quality improvement work at organizations. And if you are doing quality improvement work or you find something that works really well, it's incredibly important to publish that. A lot of our journals, Prehospital Emergency Care being one of them, take those quality improvement projects as publications as well. So if we find a program that works really well for, how we interact with or how we encourage women who are pregnant to stay in the workforce, then that's worth sharing, even though it's a lot of work to publish these things, but it's totally important and worth it.
Absolutely.
And I'll invite the other panelists to come on and ask any other final questions. I know we're getting to the end. Time flies. I want 5 hours to talk about this. I know why that last group wanted to stay on forever.
Yes.
I see Dave Page came off of mute.
Yeah, I'm just going to say amazing work. So needed, so critical. And just, we've seen all of the papers on inequity of care. We've seen stress and burnout. But in order to move the needle forward, this kind of work really gets us very focused on one of those aspects. And it's so important that we support you, that the community supports each other in just really trying to intervene now, and not just accept that that's the experience that people have and we don't intervene. And just taking and making an action list of things to either policy-wise with leaves, maternity leaves in particular, or what we can do within the education system or within the operational logistical system to be more supportive and more, it's not just awareness, because you know how you can go through that sort of chart of there's awareness, and then there's understanding, and then there's empathy, but we need to get to the action part to correct those pieces, because the team that provides care to the community really needs to reflect the community, and the community needs to be able to support the caregiver to really fully fulfill and not be threatened or afraid or dysfunctionally marginalized by the process of becoming a provider. So I'm super curious because I was excited to see that you're taking the EMT class, and now as a participant into the culture, I wonder if you have experienced some of those same things you were seeing, and how you see us moving to support other women as they progress.
So it's funny that you say that, because since starting EMT school, I'm like, oh, that's a really good research project. That's a really good research project. Just because I feel like I'm like one of you now, finally, like, like I'm so jazzed about it, that I'm like, I'm going to fix everything, my little naive dreams. But yeah, there were a couple of things, just especially like on my clinical rotations, like I said, not being able to like go to the bathroom. And I'm like, I felt so terrible. I'm like, can I go to the bathroom? And I'm like running in between calls. And I'm like, I haven't eaten in like 8 hours. I'm like, can I just shove this protein bar down? Is that okay? So like trying to think about, I had all these great ideas in my head about interventions and what's going to work. And then I sat on an ambulance for 13 hours and I was like, this would never work, Molly, like never, ever work. So I think it has helped me adapt the way that I think about things and I approach how to improve EMS occupational wellness. But specifically, as a female, I'm hoping to expand my family, and obviously volunteering as an EMT, and me just thinking like, okay, like, can I do this when I have a big belly? Like, what is that going to look like? I'm volunteer, obviously, because I have my day job, but like, what is that going to, like, how do I tell people I'm pregnant? Like, are they going to be mad at me that like, what if my doctor says I can't sit on a rig at 7 months pregnant? How am I going to be doing chest compression? Like, I'm thinking about all of these things, now having this opportunity to be in the field. And granted, I have not experienced yet, but it is helping me think about, and it's really put a lot of the issues that these women have told me into perspective. And first and foremost, the uniforms. I almost busted my pants, let me tell you. They do not fit a female's body well. And I'm not even pregnant. I hate to say it. I put it on and I said, I am a sausage in a casing. I texted my husband, I'm like, these are going to rip tonight. We're going to have to get new ones.
I can see the hearts in the Zoom coming up, because such a that has been a complaint from eternity. I've been doing this 39 years, and I have to say, when I started, there was still the concept that women weren't going to drive the ambulance, which is still true in Latin American countries, and then there's the concept of like, you will adhere, you will fit into whatever it is that we select to be your clothing. And just all of it, like two women couldn't work together. So you need to break the glass ceilings with us, and research is part of it, but advocacy, and everybody listening really should be paying attention to every one of these experiences and finding countermeasures to help really empower the workforce. So great job, really great job.
Thank you. Thank you very much.
Absolutely. And I have the really unpopular task of keeping us on time, because I could talk about this for 5 hours and there's still audience questions I didn't get to, and I'm apologizing for that in advance, but hopefully we can keep the discussion going. Emails, Twitter, all those things.
Please.
I think this is just starting a conversation, and there's much more to come. But Molly, I'd like to give you the last word before I transition us out. Is there any key final takeaway or key message that you'd like to leave our audience with?
So I think, despite what we learned, like this paper came out before I started EMT school. So that should speak volumes to EMS as an occupation and how critical it is to ensure its sustainability. And with that means keeping women in the workforce, right? We bring something to the table, so we have to figure out ways how to best do that for everyone.
Absolutely. And I will echo that as well. And I will thank you for this research. There's already a ton of comments in the chat.
Thank you.
Thanking you as well for putting data to an experience that many of us have had. I'm very excited for what's to come. There is more research on this space. I'm going to put a plug in for the International Scientific Symposium at EMS World Expo. There's some research out of California on this topic that will be present there. And let's keep it going. That is the big takeaway. So with that, I will carry us out. I'll give some reminders. I see lots of hearts flowing in Zoom. And
Thank you, everyone.
Oh, thank you, Dr. McCann Pineo.
There you go.
Pineo.
There you go.
So close. But we are so lucky to have you in EMS and look forward to reading more of your work. For those of you who routinely tune in, remember, we're going to have the Education Research Journal Club podcast. It's at a different date this month, so make sure to tune in August 16th. We will be back here with the clinical podcast on the second Monday of the month, which is September 9th. Thank you for listening, and please take these messages to heart. I think there were so many important ones, and I'll highlight if it's bothering you, let's study it, even if it doesn't make you a ton of friends. I think that's a key message that I just loved. So thank you all. With that, we look forward to seeing you on the next podcast.
We hope you have enjoyed and learned from this PCRF Journal Club. Please share it with other interested EMS professionals. An archive of past journal clubs can be found at pcrfpodcasts.org. You can also find us on Facebook at PCRF at UCLA and on our website, prehospitalcare.org. A special thank you to our sponsors, Limmer Education, providing educational tools for success at every stage of your EMS journey, and ESO, dedicated to improving community health and safety through the power of data.